In this video, we will learn about the factors responsible for joint stability in total hip arthroplasty. The learning objectives are concept of primary arc range and functional range, excursion distance in joint stability, role of soft tissues in joint stability in total hip replacement, and we will also see how implant malpositioning and soft tissue malfunctioning contribute to an unstable hip. Joint stability is determined by three important parameters: the primary arc, the functional range, and the lever range. First, the primary arc. It is the maximum angular movement allowed by the prosthesis before impinging and begin to subluxate in either directions. We will know more about the factors determining the primary arc in the next few slides. Next, the functional range. It is the range of movements in most of the activities of daily living. Flexion of about 140 degrees, extension of 20 degrees, abduction and adduction of about 20 to 30 degree range, external rotation and internal rotation are in the range of about 30 to 40 degrees. Now, putting everything together, the key factors determining the joint stability are placing the primary arc in the functional range, maximizing the lever range, and appropriate soft tissue tensioning and functioning. Let's now start with the first determinant, the primary arc range. Primary arc is also called the head-neck ratio. It is calculated by dividing the head diameter with the neck diameter. We know that the primary arc range is the maximum angular movement allowed by the prosthesis before impingement. To maximize the primary arc range, we need a large head and a narrow neck. Let's now see what happens if the primary arc is reduced. Here, we have reduced the primary arc by increasing the neck diameter. The neck now impinges on the acetabulum at a smaller angular range before beginning to subluxate. We can also see that an elevated acetabular liner has a similar effect. Constrained liners, hoods, and neck skirts also reduce the primary arc range. Now the second concept, lever range. It is also called an excursion distance. At the end of the primary arc, as the head starts to impinge on the cup, it begins to subluxate. The distance the head has to move from the point of impingement till it dislocates is called the lever range. Note that the excursion distance is the same as the radius of the head of the femur. Now, marrying up these determinants of stability in total hip replacement, at surgery we aim to obtain an acetabular coronal tilt of about 40 degrees, an acetabular anteversion of about 20 to 30 degrees. In femur, anteversion of about 10 degrees would be ideal. Note the combined anteversion of the hip is somewhere between 30 to 40 degrees and matches the normal hip parameters. Now let's see what happens if there is malpositioning of the implants. First, the version. If the acetabulum is excessively anteverted, hip is unstable during external rotation and may dislocate anteriorly. And if excessively retroverted, hip is unstable in internal rotation and may dislocate posteriorly. Similarly, if the femur is fixed in anteversion beyond the physiological range, as in acetabular version, the hip joint is once again unstable during external rotation and may dislocate anteriorly. And if fixed in retroversion, it may dislocate posteriorly. Coming to malpositioning by acetabular tilt, a more vertically placed acetabulum makes the hip unstable in adduction and may dislocate superiorly. And a more horizontally placed acetabulum makes the hip more prone for an inferior dislocation. Coming to understand the role of soft tissues, especially the abductors in stability of the hip, it can be grouped into soft tissue tensioning and soft tissue functioning. In a two-dimensional plane, an appropriate soft tissue tensioning in the y-axis is determined by the neck length. And neck length is the primary contributor to the leg length discrepancy if inappropriately replaced. In the x-axis, the soft tissue tensioning is measured as offset of the hip, which is the line drawn from the center of the hip to the tip of the trochanter. The soft tissue functioning is usually predetermined by the patient's existing condition. When the neck length is smaller, the leg is shorter, and the abductors are weaker in accordance to the Starling's law of muscle length. There is a risk of trochanteric impingement and pain. There is also an increased risk of hip dislocation. A longer neck length leads to leg lengthening, unsightly gait, and patient dissatisfaction. When the offset is reduced, once again the abductors become weak, resulting in a gluteal lurch or a Trendelenburg gait. This increases the risk of dislocation. Increased offset has a theoretical risk of bursitis leading to pain, although recent literature doesn't fully substantiate this claim. One of the important pre-surgical tools in adequately restoring the soft tissue tensioning is templating. By templating, the center of the hip joint is identified and an appropriate neck length is deduced from that. When replicated at the time of surgery, it results in a normal leg length and hence the normal gait. From the center of rotation of the hip, we can also deduce the offset. By restoring the offset, we once again achieve normal gait. Before we wrap up this video, a quick look at the soft tissue functioning of the hip joint. Soft tissue functioning is usually predetermined, and pre-existing neuromuscular disorders significantly affect hip stability. In patients with Parkinsonism, hip can dislocate either following a total hip replacement or even one of the most stable varieties of bipolar prosthesis. It is not an uncommon occurrence even in the hands of the most experienced trauma surgeons or hip surgeons. Sometimes the dislocation would have gone unnoticed for many weeks. Hence, hip arthroplasty, when it's indicated like following an intracapsular fracture neck femur, it is important to counsel the patients and relatives regarding the possibility of conversion to girdlestone arthroplasty in case of a dislocation. Other neurological and neuromuscular conditions like seizures, stroke, and myopathies also predispose to hip instability. This is the end of this video. Thank you for watching.